So thank you that you invited me to this symposium today, and for the kind introduction. Let's go into the themes now, and I will just first of all mention the agenda. We will first refer to IDH mutant glioma, and afterwards I will refer to histone H3 altered gliomas. Afterwards, we have MAP kinase altered gliomas. There are different entities described in the WHO for these tumors, and I will exemplarily refer to pleomorphic xanthoastrocytoma, or PXA, because it's the most frequent one in that group, and it can easily be mixed up with glioblastoma. Then, of course, I will talk about glioblastoma, and if there is enough time, we can go through to case examples. So first of all, let's start with IDH mutant gliomas. As you already have heard in the first presentation, there are two different subtypes, the astrocytoma IDH mutant and the oligodendroglioma IDH mutant, and I will start with astrocytoma. Astrocytoma is mostly located in the cerebral hemispheres, and mostly adolescents or young adults are affected. And the WHO lists diagnostic criteria for every entity, and they name essential and also desirable criteria. And I will just refer to this criteria exemplarily for every entity, and will concentrate on the molecular markers there. And as you see here, the essential criteria for IDH mutant astrocytoma are IDH mutations. There are two IDH genes, IDH1 and IDH2, and two hotspots there, the R132 in IDH1 and the R172 in IDH2. And in addition to this mutation, it is also required that the patient has an ATRX alteration. And what is also important probably for the molecular profiling is most of them have also a TP53 alteration. So if you see IDH, ATRX, and TP53, you can be pretty sure that it is an IDH mutant astrocytoma. The IDH mutant astrocytomas are divided into three WHO grades, grade 2, grade 3, and grade 4, which are mostly defined by histological criteria. But just for you to know, please be aware that if you see a homozygous CDKN2A-B deletion, the tumor is graded as grade 4 irrespective of histology. So if you have histologically grade 2 tumor and you see the homozygous CDKN2A-B deletion in this tumor, then it's grade 4. And this has also implications on survival, of course. Grade 2 tumors have an overall survival of approximately 10 years, grade 3, 8.1 years, and grade 4, 4.7 years. And here also the CDKN2A status is very important, because if they have a balanced CDKN2A, even if they have grade 4, they survive approximately 5.5 years. If they have a CDKN2A loss or otherwise biallelic inactivation, you see that the survival drops. So that's why CDKN2A-B status is relevant in this astrocytomas. Now let's jump to oligodendroglioma. The WHO name of this entity is oligodendroglioma, IDH mutant and 1p19q co-deleted. Also, these tumors are mostly encountered in the cerebral hemispheres, and here all patients of all ages can have this entity. Essential diagnostic criteria are also the IDH mutations. Here, the more seldom IDH mutations are more frequent. That means the most frequent IDH mutation is IDH1 R132H, which can be also stained immunohistochemically and covers 90% of IDH mutations in the brain tumors. But there can also be seldom IDH mutations, which you can only see via sequencing and not via this immunohistochemistry. So just be aware of that the oligodendrogliomas are more enriched in these seldom IDH mutations. And in this entity, you do not find ATRX mutations and also not TP53 like it's an astrocytoma. Instead, one of the essential criteria is co-deletion of the chromosome arms 1p and 19q. It's called 1p 19q co-deletion, and this is also an essential diagnostic criterion for IDH mutant oligodendrogliomas. What you can also see in this entity is a TERT promoter mutation, and this is really important because it can lead to mixing up with glioblastoma. So just be sure that you have IDH and TERT, and then you can be sure that's an oligodendroglioma in combination with this 1p19q co-deletion and not a glioblastoma. Also, oligodendrogliomas are graded in two different grades, and that depends on the histology, grade 2 and grade 3. And also here, the CDKN2A/B status is important for the prognosis of the patients because we have seen an enrichment of this homozygous deletion in grade 3. So this could be, homozygous deletion could be a hint that it's grade 3 and could also be a hint for reduced survival in this entity. Why is it important to distinguish astro and oligo? Because oligos have a longer survival than astrocytomas, most of them more than 10 years. And also, it depends, or also there are therapeutic differences, which I would like to refer. So I have to say I'm not an oncologist, I'm just neuropathologist and have more, my focus is more on the diagnosis, but I have looked into our guidelines, especially in Germany, what is listed there for the therapy, and I would like to just shortly present. When we look into the higher grade gliomas here in grade 3 and grade 4 and the astrocytomas, you see that the predominant chemotherapy is temozolomide. And you can also consider tumor treating fields in patients with grade 4 as an off-label option. However, in the oligodendroglioma, you see here the PCV scheme, which is preferred, and there are studies that confirmed that PCV works better than temozolomide in these tumors. PCV is a combination of procarbazine, lomustine, or CCNU, and vincristine. And this would be the regimen in these tumors, especially in Germany. And if you look into the grade 2 ones, you see that there is a possibility when we have cross-total resection and the patient has a low risk profile, you can just observe them after the resection. And the FDA, which is really important, has approved a targeted therapy recently. These are the IDH mutation inhibitors, and one of them is vorasidenib, and they are approved by the FDA for grade 2 oligodendroglioma or astrocytoma. That's why it's important if you have a histologically grade 2 tumor to also assess the CDKN2A/B status, because if it's then a higher grade, when they have a homozygous deletion, they would not apply for these options and would more apply for these higher grade options. Now let's jump to the histone H3 mutant gliomas. There are two different subtypes here. The first subtype is the histone H3 K27 altered diffuse midline glioma, and the second type is the histone H3 G34 mutant diffuse hemispheric glioma. Let's just start with the first, the K27 mutant or altered diffuse midline glioma. Here, the essential criterion is the histone H3 K27M alteration. Very seldomly, you can also encounter histone H3K27I mutations. So just for your knowledge, but this is very seldom. I can remember one single case I have seen with K27I mutation. What these patients also can have is ATRX mutations in approximately 20% of the cases, and also they can also have TP53 mutations. What is really interesting is that the K27 altered gliomas are almost exclusively located in the midline. So here in the thalamus, for example, in the pons, in the cerebellum, and also in the spine, or in the spine. And these tumors mostly affect young children and young adults. The former name of this entity is also diffuse intrinsic pontine glioma, or DIPG. I'm not sure whether you have heard it, but this falls under this category of K27 altered. Because of the limited resectability due to the location, these tumors have a very poor outcome with an overall survival of 11 to 16 months only, and are therefore graded as WHO grade 4. The next subtype of histone H3 altered gliomas is the diffuse hemispheric glioma with G34 mutation. Also here, one essential criterion is the H3 G34 mutation, and there are two possibilities, G34R mutation or a G34V mutation. And these tumors also almost all have an ATRX mutation in addition, and they can also have TP53 mutations. These tumors with G34 are almost exclusively located in the hemispheres, but not in the midline as the K27. And they are also not encountered in children, but more in adolescents and young adults, and very rarely in elderly patients. The former name of this entity is glioblastoma IDH wild type H3 G34 mutant, according to the new WHO classification, they are called diffuse hemispheric glioma H3 G34 mutant. They are also known to have poor outcome with overall survival of 18 to 22 months, and are therefore also graded as WHO grade 4. So let's look into the MAP kinase altered gliomas, and I will just refer to the pleomorphic xanthoastrocytoma, or PXA, because it's the most frequent one among this group, and it can be easily mixed up with glioblastoma, which would also have prognostic implication, because PXAs have grade 2 or 3, while glioblastoma has grade 4. And there are also therapeutic implications, which I will refer to later. Due to the WHO classification, PXAs are mostly classified by histology. I think this is a little bit tricky, and I would recommend to do molecular profiling here, especially for MAP kinase alterations and for CDKN2B homozygous deletion, because what we see in the molecular profile of these tumors is that most of them, 60% approximately, have BRAF V600E mutation, and there are other PXAs that have other BRAF mutations or also other MAP kinase alterations, for instance, in RAF1. And this MAP kinase alteration in combination with this homozygous deletion of CDKN2AB is a good hallmark of this entity, particularly when we do not see any other alterations that would probably be suggestive of glioblastoma. So that means this entity is characterized by MAP kinase alterations, mostly BRAF, homozygous CDKN2A deletion, and lack of other alterations that could be probably hint to glioblastoma. These tumors are located predominantly in the hemispheres, and as you can see here, they are almost often located superficially, in the cortex and may sometimes have contact to the leptomeninges. They occur in children and young adults, and rarely also in elderly patients. They are graded into 2 grades, grade 2 or grade 4, according to the mitotic count. And grade 2 tumors have a 5-year overall survival of 90%, and grade 3 about 57%. And now let's look into glioblastoma, because this is, of course, the most frequent malignant brain tumor in adults and also in elderly patients. So when you are 30 years or older, then glioblastoma gets more and more likely. The first essential criterion is that you have a diffuse astrocytic glioma, which is IDH wild type and histone H3 wild type. And then one or more of the following criteria have to apply in addition. First, microvascular proliferation. This is something you can see under the microscope. And necrosis, of course, you see under the microscope, as you can see here in this picture. And then a TERT promoter mutation can be a criterion in combination with IDH wild type, of course, because if it was IDH mutant, you have to think about oligo. An EGFR amplification or a chromosome 7 gain combined with the chromosome 10 loss, which is called 710 signature in the neuropathology slang. So yeah, these are the criteria for glioblastoma. And as you know, these tumors are mostly located in the hemispheres of the cerebrum and very rarely in the cerebellum or in the spine. And these patients also have a poor outcome of 1.6 years to 2 years overall survival and are graded as grade 4. And when you see the histology here of this giant cell glioblastoma, and we go back to PXA, you see that histologically they look very similar. So that's why only classification by histology is a little bit critical in my opinion. And now I would also like to refer to the therapy and to some differences in these entities we have discussed so far. The first entity is the diffuse midline glioma, K27 altered. Here it has been shown that temozolomide is not very efficient, and that is why radiotherapy only is given to them in Germany. But there are also a lot of clinical trials referring to this entity with new agents that are tested, like ONC 201, ONC 206. Then there is GD2 as a tumor-associated antigen, which can be stained via immunohistochemistry. And against which CAR T cells can be applied, and also the alterations which are or often the same in this entity. You can also give peptide vaccines against this K27M mutation, and you can also combine them with checkpoint inhibitors. But this is only in the framework of clinical trials at the moment. Then we have diffuse hemispheric gliomas. These patients are very seldom, and that's why we have not a lot of clinical studies here. They are treated like glioblastomas at the moment due to lack of an alternative. But of course, also here you have this G32 mutations, and can also, in the framework of trials, address this mutation via immune therapy. In the PX8s, we have when we have a BRAF or another MAP kinase alteration, then of course you can think about dabrafenib or trametinib as a therapeutic option. So in clinical trials, MEK inhibitors and BRAF inhibitors are tested at the moment. A standard of care would just be radiotherapy here, plus and minus TMZ or CCNU. But in case of tumor progression, you can also have these options with MEK or MAP kinase inhibitors. And in glioblastoma, in patients up to 70 years of age, the standard in Germany is radiotherapy plus concurrent TMZ plus TMZ maintenance. And also you can think about adding tumor treating fields to the therapy regimen. And in patients over 70 years of age, or in patients who are in compromised clinical conditions, who would probably not be eligible for a combination therapy, MGMT promoter methylation testing may be insightful. In these patients, you could, in case of MGMT promoter methylation, give TMZ only, or in case of MGMT negative status, radiotherapy only. And there are also a lot of therapeutic options in case of progression, like, for instance, bevacizumab, regorafenib, CCNU, or also inclusion in clinical trials. Now let's come to two case examples which illustrate how important molecular diagnostics can be in some instances. We have one patient who came to us with glioblastoma, with the external diagnosis of glioblastoma, and we also did comprehensive molecular testing and histological assessment. We saw a diffuse glioma with singular mitosis only and no necrosis, no vascular proliferation, so nothing really helpful in his case of histology. Our molecular findings were BRAF V600E mutation, a homozygous CDKN2AB deletion, and lack of molecular markers which would hint to glioblastoma. And that's why our revised integrated diagnosis was pleomorphic xanthoastrocytoma CNS WHO grade 2. The patient was very happy about it. And yet now he has also the option of a BRAF inhibitor in case of progression of disease. And the second case was a case we received from an external customer, where the external diagnosis was suggestive of low-grade glioma. Indeed, when we looked into the histology, it was a very diffuse process with only diffusely elevated cell density, but nothing real else which you can just grab on the histology side. And then we did molecular analysis, and we found IDH83 wild type, of course. And then we saw an EGFR amplification and also a TERT promoter mutation. And that's why our revised integrated diagnosis was infiltration zone of glioblastoma, IDH wild type, CNS WHO grade 4. And yeah, we do not know what would have happened if we did not do this molecular analysis, whether they just did watch and wait or so. And so the patient could receive an adequate therapy. And this is my last slide. I hope we are in time. There are also, when you do comprehensive molecular testing, there are also other alterations which you can find across entities and which you probably can discuss as an option in a molecular tumor board. And here listed below, I have some alterations which we found across entities in gliomas, in different gliomas, and which we also discussed in our molecular tumor boards. For example, there can be other EGFR alterations that are activating, for instance, the variant 3. Not only amplifications, but also activating variants can occur, especially in glioblastoma. And there you can consider these EGFR inhibitors. Then across entities, you can also have mTOR alterations with where you can have give temsirolimus or everolimus. NF1 alterations can occur in low-grade gliomas, but also in high-grade gliomas, where you have the possibility to give MEK inhibitors. FGFR and MET and also NTRK can qualify for FGFR, MET, or NTRK inhibitors. Then we have alterations in the CDK pathway, where you can give CDK inhibitors, like, for instance, abemaciclib. Then we have PTGFRA amplifications or activating mutations, where you can consider regorafenib or dasafinib. And some patients or lots of patients, lots of glioblastoma have VGFA overexpression on RNA level, which would qualify them for bevacizumab therapy. So with this, I would like to thank you for your attention, and I am happy to take questions. I'm sorry, we cannot hear you online.
Yes, can you hear me now?
Yes.
Thank you to you for the enlightening session and showcasing the practical applications of molecular diagnostics in glioma. Now, I would like to ask the participants to give out their questions, if they have any. First question from Professor Dr. Kamcham, sir.
So, and thank you for your nice presentation, especially. Really, we got a good ideas about the molecular signatures of the brain tumor, especially. So, from your experience,
Sir, we're not able to hear you.
Rajesh, can you hear me?
I can hear you.
Oh, and
at the moment.
Now we can. Yeah.
Okay. Okay.
And thank you for your nice presentation, especially. So, from your experience, what especially in all brain tumors, we should go for the comprehensive genomic profiles because you see a lot of mutations are coming up, especially the coming days, especially, and we can have some off-label target therapies also in that cases.
Thank you for the question. I think it would be good to have a panel of markers that you assess in gliomas. And my suggestion would be to look in every glioma for IDH, of course, then for ATRX, TP53, then for H3, K27. H3, G34, that depends on the location. When you have a midline, you can just leave G34 and just do K27 assessment, or the other way around. When you have a hemispheric tumor, and you could leave away the K27 and just make G34. And you can also do BRAF in this in glioma patients. And then third, EGFR. And if you have the assumption that it's oligo, you can also go for 1p19q. And I think then you have a really comprehensive panel of markers you could test. Some of them you can address via immunohistochemistry, of course. In some you can do sequencing analysis. And these 1p19q, if you do not have any or if you do not have comprehensive testing methods, which look for copy number alterations, probably a FISH analysis would also be helpful. Also for probably 7 gain and 10 loss.
Thank you, Dr. Reinhardt, for your excellent answer. Any further questions? And our participants in Zoom, you can also ask questions. If you have any questions, please put them in the chat.
Well, sir, do you like to ask any question? Then I have one.
No, Shajan.
Okay, thank you. Dr. Professor Anne, I just want to know about that situation in Bangladesh. What happened that we have only histochemistry based some tests like we can do the methylation, we can do the IDH with immunohistochemistry. But sometimes how the concordance of IDH immunohistochemistry and in PCR or for the 1p19q relation, how often you find this type of alteration in immunohistochemistry and PCR?
The IDH mutations via immunohistochemistry is very seldom. Most of the adult patients have glioblastoma, and sometimes I have the experience that the staining is interpretable with limitations only. But what would help in addition then in the astrocytomas is ATRX. I think you see loss of ATRX more reliably, I think, than IDH. And if you have P53 staining, of course, or molecular testing, then this would be also helpful in case of astrocytomas. But of course, when you have adult brain tumors, then the most frequent is glioblastoma, and then you do not see these IDH mutations so frequently. I'm not sure. Was this the question you had?
Regarding we have only in Bangladesh, we have only the excess of immunohistochemistry for the IDH as well as LGMT and immunohistochemistry based. No PCR for the 1p19q deletion or so. What is the concordance of this 1p19q deletion in the PCR and immunohistochemistry for the IDH? Do you have any comment?
The 1p19q deletion is not very frequent because oligodendroglioma is also not very frequent. And yeah, I'm not sure whether this is whether it's worth to establish. You cannot really do it via immunohistochemistry, but what you can do via immunohistochemistry is when you have an IDH mutation and you see it via immunohistochemistry and you have retained ATRX staining and no TP53 staining, then you can also be pretty okay with the assumption that it's oligo.
Okay, thank you.